Hello, my name is Kinichi Hotta. I'm the chief of Division of Endoscopy at Shizuoka Cancer Center in Japan, and I'm the corresponding author of this study. Our center is located in a beautiful nature-rich setting surrounded by both mountains and the sea. Nearby stands Mount Fuji, Japan's highest and most iconic peak. The center is renowned for its advanced diagnostic and therapeutic endoscopy team-based approach to cancer care and commitment to clinical research. We serve as a regional and national referral center, dividing all types of cancer treatment and contributing to the advancement of gastrointestinal oncology. If you ever have the opportunity, please do visit our hospital.
Hi, I'm Taishi Okumura, the first author of this study. Now I'm an endoscopist at the Digestive Disease Center at Showa Medical University, Northern Yokohama Hospital. From 2020 to 2024, I was a member of Shizuoka Cancer Center, where I conducted this study. It is a great honor to present our research, comparison of survival and recurrence between colonic and rectal tumors after resection in T1 colorectal cancer, a long-term cohort study, which has been accepted for publication in GIE.
Dr. Okumura, could you explain the background and purpose?
Certainly, colorectal cancer is a major health issue. T1 cancers are increasingly detected due to screening and endoscopic advance. While risk factors for lymph node metastasis are known, the impact of tumor location, colon versus rectum, on long-term outcomes is unclear. The rectum's anatomy may affect progression and recurrence. Our study aimed to clarify survival and recurrence difference by tumor location after T1 cancer resection.
Thank you. What method did you use?
Of course, we analyzed 987 patients who underwent resection for T1 colorectal cancer at our hospital between 2002 and 2020. Patients were classified into 3 groups based on pathological risk and treatment strategy. Group A, low-risk T1 cancer after endoscopic or surgical resection. Group B, high-risk T1 cancer, endoscopic resection only. Group C, high-risk T1 cancer and after endoscopic and surgical resection or surgical resection only. Being compared disease-specific survival and recurrence by tumor location.
What was the main result?
Yes, Group A and B showed no significant difference between colon and rectum. However, in Group C, high-risk patients who underwent surgical resection, rectal tumors had a significantly higher cumulative recurrence rate, 4.8% versus 1.1%, and lower disease-specific survival, 98.2% versus 99.8% compared to colonic tumors. Multivariate analysis identified rectum location, venous invasion, and high tumor burden grade as independent risk factor for recurrence. Notably, all recurrence in rectal cancer were distant metastases, mainly to the lungs.
Could you briefly present a representative case?
Certainly, an 80-year-old man underwent screen colonoscopy, which revealed a 14 mm lesion in the lower rectum. The lesion showed high malignant potential. He underwent surgery with lymph node dissection. Pathology revealed submucosal deep invasion, lymphovascular invasion, lymph node metastasis, and high tumor burden. Recurrence appeared in the lung and brain, and he died 39 months post-surgery. This case highlights the aggressive nature of high-risk T1 rectal cancer.
What is the significance of these findings?
Our study shows that high-risk T1 rectal cancer has worse outcomes than colonic cancer after surgery. A rectal location should be a prognostic factor, and patients with venous invasion or high tumor burden need close follow-up.
What is the future direction?
Clinically, guidelines should include tumor location in risk assessment. Research should validate these findings and explore adjuvant therapy effectiveness. Separate prognostic models for colon and rectal cancer may improve management. In conclusion, after resection of T1 colorectal cancer, especially in high-risk cases, rectal tumors show higher recurrence and mortality rate than colonic tumors. Careful and continuous post-operative surveillance is essential for these patients. We hope our findings will contribute to improved patient management and future research and guideline development in this field. Thank you very much for your attention.